Right, let's move on to question 5. I'm sure there's a lot of the themes that are overlapping, but question 5, you were looking at how can it be ensured that the public and patient views impact at all levels of the system across the NHS? Who's picked it up, right?
We addressed this as a systemic question, so we had a bit of a discussion about what we meant by the system, and definitely we're talking about it as across health and social care. We started by talking about using a physiological metaphor and reminding ourselves that systems avoid entropy by having feedback, and that led us to discuss 4 main points really about the type of feedback and how that was going to happen. So the first one was around the overall approach to feedback and complaints and how we respond. The second one was around professionalism. The third one was around system design and how that could be used to create better feedback. And the fourth one was around regulations. So in relation to the approach to feedback and complaints and how we respond, we reflected a bit on the John Lewis idea that every partner is a complaint handler. And we were thinking about the much more extensive use of all of the tools that have been mentioned by previous speakers, that there are an awful lot of tools that are already available that people just simply don't know about them. So those were examples around experience-based design, carer cards, a range of examples that people could use. So
why do you think they don't get consistently used? The stuff's out there.
I think I think that does link to the question about professionalism, that actually people often don't think it's that important. Yeah. So that is something we definitely do need to tackle. I think that links to another point we made around there's a problem with describing things as positive and negative feedback, because what some people think in raising a concern is quite a positive thing is often experienced by others as being quite unhelpful and not welcome. Yeah. And I think we've had plenty of examples where patients and staff have raised questions and raised concerns, and their experience has been pretty negative in providing that feedback. So there's a serious issue there that has to be tackled. That led us into thinking about actually what we should be measuring is not the level of complaint but the level of feedback generally, and what we should be thinking about ways in which that can be made more public, as previous people have talked about. So onto this question of professionalism, we felt that there was a real need therefore to have a much more honest and courageous conversation within and across professions about the way that care is delivered, and that includes discussions about things like responsibility and accountability, where that lies, how care is coordinated across the system. We talked about examples of generalism and extensivists, so people who were...
You'll have to explain that for us, because
okay.
I'm not sure I'll understand what you're going on about.
This was a point that Martin was making about, rather than thinking about people as having very specialist, intensivist type skills, that actually we need more people who are taking a much more extensive view across the whole patient pathway.
It's about, in medicine, things are getting more and more specialised, so they don't see the whole person anymore.
Yes. Okay. Yeah. And alongside that, we also talked about the many different approaches that would challenge quite a number of beliefs about professionalism, but that were really important in terms of patient voice. So things like shared decision making, and approaches that were about really getting the basics right reliably, back to that theme that we've discussed in previous seminars. And I think that also comes back to the issue around how standards of acceptability are set and how people are then held to account. And I guess one of
there are clear standards of acceptability at the moment?
I don't think so. I think people can interpret that as they will, as we were talking about earlier on, that things are optional. And that there isn't a sense of what is ultimately acceptable or not. And I don't think that's something that can be imposed externally. It's something that has to be negotiated and discussed on a constant basis. One of the issues about providing care, I think, is that when you're actually laying hands on a patient, you should be asking for feedback then and there about what the experience is like. How does this feel? Is this okay for you? That should be part and parcel of everything that goes on. The third element is around system design, and this is kind of a big issue, and I didn't really ever thought I'd find myself saying this, but thinking about the opportunities that the reforms offer in terms of whether now is a really good opportunity to have those conversations about integration across health and social care, and the opportunity for using clinical commissioning as a way of really challenging some of the practice that's out there and saying we're going to have to make some difficult and courageous decisions about decommissioning services that just are not good enough. And simply that we are challenging the idea that some of what we're talking about is trying to fix a system that is fundamentally unfit for purpose, and the theme that that's come out in other seminars as well around we are delivering care to large numbers of older people with extensive comorbidity, and that frankly they shouldn't be in hospital to start with. That's not where you would start, and that therefore listening to and thinking about what people really need and then commissioning for that rather than doing what we do currently is really very important. And the fourth area was around regulation and about changing the culture of regulation so that the focus of regulation was very much on patient experience, and we talked about the importance of integrating finance and quality, because that is what would create value.
There's loads in what you're saying there. Any things that people would like to add? If you haven't said anything, so.
Thanks very much. Deborah Alside, NHS Choices. It was just coming back to the point that you made about people not knowing that things are there. We've just very recently, over the last couple of weeks, maybe it was in preparation for coming here, done a bit of research through NHS Choices about patient commenting. Now, it's a small cohort, there's only 860 responses we had, and also it's caveated by those are people who are already online. But of that 860 people, 63% haven't used commenting functionality around health because it hadn't either occurred to them or they didn't know it was there. They didn't know they were able to. So I think that's, again, small, bounded, it's a research, but that's the reality.
But there are now more outlets for them to tell their stories. NHS Choices, there's patient stories, there's lots of different people with badges that suggest they might be interested in collecting patient stories.
It just shows we've got some work to do to improve that level of knowledge, to be able to utilise that as a mechanism.
Absolutely. Okay. Who else was wanting to come in?
Just listening to what you had to say on the last table, and as a patient with multiple long-term conditions, one of the impacts I felt, and I'm sure many patients feel, that we forget in the system is actually the changes to current booking systems and the fact that they actually hinders continuity of care, which is damaging to both the professional and to the patient. There is frequently patients actually see a different consultant every time they go to the hospital. It's not the consultant's choice, it's not the patient's choice. If we're going to truly value shared decision making and the values of continuity of care, we have to look at the current booking systems.
Susie, are you referring to the fact that this is because somebody else books the consultant's diary?
A non-clinical administrator who isn't even attached to the speciality is now responsible for making the bookings, and then they are not allowed to change the booking. So if a patient's booked with the wrong consultant, the right speciality, it can't be changed, and it's wasting money and it's hindering patient care.
Yeah, and they can't change the link to the appointments either. Okay, let's move on then. Was it on the same point? Yes.
I think the colleague's last comment illustrates something that I wanted to say, which is that unless we go out and listen to families, particularly mostly people with long-term conditions who are using a variety of services across a variety of organisations, we start to hear answers to questions we haven't even thought of asking.
Yeah.
And I think, we did talk a lot about how we get systematic patient and particularly family stories, actually, carer stories, about not just the hospital stay, but what happened before the person went in hospital and what happened after they came out.